it's probably worth going back a little bit. So C2AI was actually born in the Northwest. Our Chief Medical Officer was a mathematician before he became a general surgeon here in the Northwest, working in Worcester. He was also audit czar for NHS England, and he was asking the question of himself: how can I compare one group of patients with another, and particularly if they have got a different makeup, different sort of case mix, and so that you can have a better understanding of how you compare apples with apples. And the idea was that how do you compare one group of patients, let's say at a teaching hospital, having a similar operation but in a district general hospital. They may be very different patient cohorts with different underlying conditions and different risks. So he essentially developed an algorithm which takes into account the patient's physiology, the type of procedure they're having, their comorbidities, to better understand at an individual patient level what their outcomes should be, and therefore you compare them to what actually happens. And by doing that, you can actually help inform variance of practice, excellence in practice, but also opportunities for quality improvement, and be able to track that over time. And essentially that was the premise of taking existing data sets, and as we all know in healthcare, we're overwhelmed with data, but the problem with it, it's often siloed, and often you can't make sense of it because it's very generic and very at a very high level. So taking that data set and really boiling it down to an individual patient's need, and therefore understand what needs to happen and what should be happening for those patients, but also being able to think about what the remedies might be in order to improve health outcomes, and then see the benefits of that and track that over time. Bridging the gap, I think, has maybe a couple of different elements. One is being able to understand what the needs are of a patient, and often, as I said, there's lots of information about patients that sits in various silos, but how do you turn that information into insights and then into action? So often there is a gap in terms of that data being able to be utilised both by the patient and giving them autonomy, but also in terms of clinicians being able to utilise that information in order to best serve their patients. The other thing is that we're working in a very constrained environment, and of course, when you're working in a constrained environment, anything that you do may, either intentionally or unintentionally, as is often the case, have a deleterious effect on vulnerable groups of patients. This whole idea of the inequity between delivery, and that might be because of their deprivation or might be because of their ethnicity. And so being able to pull out and tease out that information so that decisions that are being made aren't disadvantaging vulnerable groups is a big part of what we do. And being able to understand that not only at a group level, but down to an individual patient level. And then I suppose there's the kind of commercial end of it, which is actually how do you deliver that insight at scale within the NHS? And I think the reality is that it's a very difficult thing to do. The NHS isn't one organisation, it's very fragmented, and actually you can only really do it in bite-sized chunks. So the way we've chosen to do it is working directly with clinical colleagues, working with organisations like the Innovation Agency that sort of help us navigate the sort of ecosystem of different providers and different collaboration partners. And then by working collegiately, we can then deliver on that. Often we've done it on a region by region basis, developing case studies, generating real world evidence, and then the idea is that we can then scale that and hopefully take that to new regions.